set up here. All right. First, I would like to thank Christine Pond and Holly Hagel of the Addiction Technology Transfer Center Network for even asking me to present on this important topic. Special thanks to Christine for her assistance in helping me prepare for this webinar. I normally do a lot of face-to-face presentations. And finally, I appreciate all of you who have tuned into this webinar today. What I've done in my presentation is periodically throughout I will have a slide where it kind of summarizes an indication that I'm going to another area, and at that time I'll kind of ask if there's one or two questions related to the material that I covered. My experience, my journey here is as indicated primarily in formalized treatment, and in 2007 I joined Grant Medical Center. At that time, I wanted to kind of explore what was an evidence-based intervention to implement on the trauma unit, and that's when I began to do my research on SFIRT. And it's really been a great opportunity to practice and implement an evidence-based and best practices approach. So what I'll do is I cover some of this information. I will give some of my experience of working at a trauma center and the benefits and challenges that I've come across as it pertains to referral to treatment. I'm going to explore some of the patients who commonly seek treatment interventions and those who have been resistant. I will go over a few vignettes. Some of the common barriers of why patients do not receive treatment historically. Identify patients who need a referral for further evaluation, collaborative efforts between both the medical and treatment providers. One of the things that I have found out, it just seems in Ohio, everyone kind of operated in their own silos, and I knew that in order for the interventions to be effective for those patients who needed actual treatment services, I really needed to go out into the community to the treatment providers to create that collaborative effort to make it kind of a seamless approach to refer patients to treatment. And then in the second part of the presentation next week, we'll actually dive into what are some of the different treatment levels of care, the dimensions, some of the assessments, and treatment options for special populations. I think we all kind of know the definition of screening and brief intervention. For the purposes of this training, I am going to touch base on screening, not necessarily to define it, but how I use it to identify patients, screen them, as well as refer them. I'll give a framework on how I present the information to the patient by the use of brief intervention, and then we'll go into some referral. And as I said, I'll leave next week primarily to a referral and treatment. As far as settings, I think we all can agree that SFIRT can be proven to be beneficial in multiple settings. Just last week, I was asked to speak to some social workers and case managers who are doing a lot of work with older adults and who are very challenged by the substance abuse epidemic among older adults, the baby boomers as they get older. And in our particular area, there are identified programs that treat older adults, but they definitely need to improve. And so a lot of the staff was kind of like their wits in on how to identify and what to do. And so it's good to see that not only hospitals but other areas are beginning to implement this approach. Having been in the field of addiction for a long time, I've only operated on the one continuum, which was the abuse and the addiction, the withdrawal. But clearly, SFIRT is an opportunity to help folks identify and prevent and identify individuals. As we begin to look at, what screening and brief intervention is aimed primarily, it's to, look at these patients who we look at their current use, their binge patterns, as well as heavy use. And a lot of research has proven that not everyone that we see is going to need an actual referral to treatment, but that everybody is recommended to have the screening and the brief intervention. And the brief intervention can be for those people who are drinking within normal drinking limits, and congratulating them and encouraging them to continue, particularly when prescribed medication is part of the care. But then there are those who, obviously, in doing a screening brief intervention, depending on the screening tool that is being utilized, is a clear indication that they need further evaluation and or treatment. And the National Study of Drug Use Health have continually every year puts out these statistics. It's usually 2 years back, and so we see in 2011 when it comes to alcohol continues to dominate, and then of course we have the prescription drug epidemic that's occurring now. And I always find it interesting that particularly in the medical setting that a lot of medical professionals focus primarily on heroin and cocaine, but forget that alcohol is the #1 substance that is being abused, and of course prescription drugs. So whenever we do our screening tools, I think it's important that when we look at screening tools that we look at those that is definitely going to capture the alcohol, and can if you don't have a tool to address the drug use, it's important still to ask those questions. This was the slide that really just kind of hit home for me. That kind of I just kind of went on my soapbox or bandwagon either way here in Ohio to say, hey, we need to do something about it. Ohio does not have a universal screening and brief intervention program statewide. There are several sections of Ohio that are either, I think Kettering, Ohio, received a grant to train residents, so I know in that area, the Dayton area. And then there are a few others, Youngstown, who I've worked really hard along with Kettering to train a lot of their professionals. But that 95.3 is very alarming. I think whenever I do screening and brief intervention, it's this slide to me that I really kind of bring home to folks to help people realize that people are not getting the treatment that they need for a lot of reasons, and we'll cover some of those. But one of the things that I find that's very beneficial is that when we look at screening and brief intervention, I believe that this particular intervention helps address that 95% of folks, and to kind of get a better idea to help people to look at their substance use and or treatment if needed. I think it's important. I think we all can agree that stigma and discrimination is a huge reason for that 95% not getting treatment. People are very scared to go to treatment, whether it's not wanting their employers to know, not wanting it on their insurance plan, fearful of what family members will say. It was just yesterday I met with a gentleman who was assaulted, and as I was exploring his marijuana positive screen, he was very fearful and tearful that I not disclose the information to his wife in fear of that relationship deteriorating further. So there's a lot of reasons of why people do not get the help they need. Being a social worker at the College of Ohio State University, I do a big push on educating social workers. Not every social worker obviously wants to specialize in addiction, such as myself, but I think we all know that depending on whatever setting, there's a lot of social workers that are present in a lot of these social service agencies. And for those who do not want to specialize in alcohol and drug addiction programs, that screening and brief intervention is an ideal intervention to help them. And as you can see, based on the NASW standards, it asks that social workers be able to screen, assess, and place, but it does not say that they have to treat. So I think when I present this to a lot of social workers, some of them feel relieved, just because that's not a patient population that they necessarily want to specialize in. When we look at screening, these are some of the things that trigger myself, my coworker, and I intern students from some of the area colleges, and it's these identification risk factors that even trigger why we need to see a patient. When we go in every day, we kind of go into a patient's chart to look at labs. That's our first thing. And there may be a positive lab, but if there isn't a positive lab, that doesn't stop us from exploring further, because right now all of our trauma docs do not lab test everybody. So what we're looking for is any kind of indication in the chart, whether it be the emergency room record, the history and physical, consultation note from pain management or behavioral health, the nursing assessment. The quick screen is more like the nursing assessment, and or family or friends. in the chart, whenever we see anything other than labs, that is an indication for us to meet with a patient. We admit about 4,000 patients per year, so right now I don't have the necessary man or woman power to screen every single patient. So right now ours is mainly, as patients are admitted, who are the patients that have this obvious notation one way or other to provide intervention. Now, I think it's important when we, this is whether it's inpatient or any other setting, is that we look at the toxicology testing for what it is. I try and educate the medical team constantly that if you have a positive alcohol lab, that does not indicate alcohol dependence. If someone is positive for a cocaine lab, or if you have a prescription drug, it's the one thing about toxicology testing is that is what is present in the patient's system currently. Now, of course, we could look at a grid and determine when someone has used a substance, whether cocaine usually a 72-hour period, marijuana can be a 30-day period. So one of the doctors, Dr. Prasanna Depa, she's an addictionologist that I work with, and she helped me really pay attention to this, that the lab test is a lab test, but it is not a screening because it does not detect the actual abuse and physical dependence or addiction to a particular substance. In our cases, when we look at a lab, if the patient is positive for opiates, heroin falls behind. In our lab test, we don't necessarily test for the heroin, but it falls under opiates, and so a lot of times we have to be careful with that. However, lab test is a good indication, obviously, to meet with a patient. I love this particular instrument. We use this at the hospital, and the reason I'm giving you this information because when I do my brief intervention and I say, okay, here is a reason for a referral, I use all of this information to support why I'm making that referral, because a lot of times in the hospital settings, patients want to know, one, why are you even testing me, and then two, why are you making this recommendation? So that's another reason, as I scan through the chart and gather different information, that is usually I'm building up to, if this patient needs further treatment services or interventions, this is the information that I pull out. Now, there is another scale for women. I just happen to cut and paste this one, but it's always interesting whenever I do trainings face-to-face, or even when I meet with patients, I always ask the participants, what is the number of substances that people always say that they've used despite their alcohol lab. They can have an alcohol lab of a 0.38, and patients will say they only had 2. And I always ask 2 of what? It's always, is it, your 12 ounces, we're talking 240 ounces. We tend to laugh with that, but, it's very important that we ask that question, because a lot of our patients, at least the patients that I've worked with, never received or even understand the standards of drinking as for a woman and a man. And I can't tell you how many times I've ran into patients who've suffered severe injuries and or death of someone in the car, and they say that they only had 2. In all reality, they did have 2. It just happened to be 2 Long Island iced teas, which is quite different. So a lot of times patients will say, some say, well, they're lying. Well, are they really lying? I had a young lady who said she had 2. Her alcohol level was a 0.2, I don't know, 0.2 something, kind of a lower number there. And she told me she had 2. She did have 2, but when I explored what she had, it was equivalent to anywhere from 10 to 12 drinks, which supported her alcohol, the alcohol lab she had. Now, this particular slide I like to kind of play with a little bit here. I'm going to try this. When we look at comprehensive assessment, this is the process. When you look at a treatment facility or go to a treatment facility, a lot of times when patients are admitted to a treatment facility, there's a lot of paperwork that they have to fill out. Sometimes there is a screening instrument just for self-report purposes. But there are obviously risk factors to even justify why a person is being referred to a treatment facility. And it may be a patient identifying what those risk factors are, or it may be a probation officer or family member. And then there's this initial screening, and then there's usually someone that will sit down with them when able that will do a more extensive comprehensive assessment. That can be the Addiction Severity Index, and in some cases other instruments. From that screening, that assessment, now we're going into, based on what the findings are, it determines what are the appropriate interventions. And like I said, next week we'll talk about the inpatient, the outpatient, the intensive outpatient, and then of course upon completion the evaluation. I like to, when I talk about screening brief intervention, I like to draw a line here, and I always like to say it's this area that we're doing the screening and brief intervention. And when we make the referral and treatment, this is where we're saying seek further assessment, further evaluation, further treatment, so that when a patient makes that appointment, then they're usually going to see someone who's going to do this. Now, when we come over here to doing the screening, brief intervention, the referral and treatment, what I have found, and I presented this just the other day in Youngstown, is that in a hospital setting, what I have found, based on a person's injury, based on their severity of substance use, that sometimes we have to provide the treatment in the hospital setting by way of the alcohol withdrawal using the C scale, or the opioid withdrawal using the CAL scale, and these are usually instruments that nurses and doctors complete. And I don't know, I've been doing this for a lot of years, and for some reason I got that aha moment that, yeah, the person may need that additional treatment once they get out of the hospital, but from a medical standpoint, we have to provide some form of treatment to address that alcohol withdrawal or opioid withdrawal. I think when we look at screening and some of the screening basis, screening is obviously not an assessment. However, a lot of those tools have different elements that indicate criteria is being met for a particular diagnosis. At the trauma center that I work at, myself as well as the clinician that works with me, the counselor, we do diagnose, mainly because when we screen, we ask more thorough questions and are able to identify the different criteria to support that diagnosis. But when my interns go in to do a screening instrument to gather information before, I go in, they are not. They're just gathering the information that I need to kind of do a further intervention. And then again, SBIRT to prevent, identify, and intervene. Though for more intensive services where especially needed, I kind of associate this with patients who are in the hospital and need that further withdrawal protocol. And then here is just whether it's the DSM-IV, soon to be a DSM-V, and then the ICD-9s. I think it's important when we look at the substance use disorders. Our treatment centers, when we make referrals to treatment centers, a lot of times we're seeing abuse, we're seeing dependence to justify that referral. A lot of treatment centers will address binge drinking by way of maybe educational programs. But I think, when you start looking at referral to treatment, it's important that you understand the different criteria. And maybe I'll put that up next week of, criteria for abuse and dependence for those that don't know. Now, it's here in your the intoxication that I find at the hospital is a lot of times if a patient does not meet medical need for admission to the hospital and they're in the emergency room, we try and do an intervention to, once their alcohol level comes down, to have a conversation to even see if the patient is interested or even meets the criteria for further treatment. And then, of course, the withdrawal, which I've already spoken about. So what I'm going to do is, at this point, I'm just going to allow, if there's one or two questions that Christine sees, and based on any of the information I've already provided, I'm more than willing to answer one or two questions at this point.
I had a couple of requests for your slides, so
okay.
Maybe like when this is over, you can send me the slides and I'll get them out to the attendees.
Absolutely, I can do that.
Okay. And one person asked, what are the names of the withdrawal scales again?
For the alcohol, it's CIWA. It's called the Clinical Institute Withdrawal Assessment. Again, my experience has been nurses have completed those in your detoxification programs. It's linked to a particular treatment center. And then, of course, in your hospital setting, a lot of nurses I don't know, it's interesting. I say they should be aware of it, but sometimes depending on the curriculum and what education they receive, some nurses are very comfortable with that tool and some are not comfortable with that tool. There's some subjective components and objective components. I really think nurses need to be trained in this area. And then the COWS, C-O-W-S, is the clinical opiate withdrawal scale. And that is for opioid withdrawal.
Okay, that was the only question, and I tried to email everybody, but just so they know, quite a few of these screens are available on our website, and that is at www.ireta.org/EBE, like evidence-based practice expert. So that's EBPSBIRT. And they can just go to ireta.org and wander around and find a lot of these there.
Okay.
Or they can just get them from Googling, because I know that they can get the charts easily. Here's one more question, and then we'll go back to your session.
Okay.
Based on the alcohol per weight chart, it's important to discuss that Ohio is zero tolerance with OVI.
Mm-hmm. So what's the question?
That was just, I think that's just a question, or maybe it's just a comment. Based on the alcohol per weight chart, is it important to discuss that Ohio is a zero tolerance with OVI?
Yeah, I think it's important to discuss some of that, and that's an interesting point. You know, even with adolescents, and even with the Ohio has a brochure that I give a lot of patients when it comes to OMVIs, because that's another intervention that I do, because some of our patients, due to their injuries and they're admitted to the hospital, a lot of times those court dates are set and they can't actually get to court, obviously, and if they don't get to court, there's usually a warrant. So even, I find, even with patients who are a little guarded or resistant to my intervention or a little frustrated, whenever I mention potential OMVI and some of the documents, that really brings their awareness to someone, know that they've received a ticket, and just because of pain and just being in the hospital, they forget, and or some are actually delivered to them while they're in the hospital. So yeah, a lot of education around, you know, what are the standards and stipulations that pertains to alcohol consumption. Yes, that's a very good point.
Okay, that's it. Thanks.
Alrighty. Screening tools. I'm going to share some of the screening tools that I use over at our facility, but this is this isn't all of them, because the craft obviously is not in here. These screening tools here are primarily for adult, or all of them are adult. Your assist is going to cover alcohol and drugs and tobacco. Your audit C, it's really your audit tool, but it's the first 3 questions, and I'll kind of show you that when I get to that tool. We usually will do those on some of our random cases. That's a patient, there's no evidence of a lab, there's no evidence of any substance use indicated in the chart, and so this is one of the first instruments that I have the interns use before I go in to complete it, kind of getting them a little bit more familiar with the tool. And then of course the audit. Your CAGE is alcohol, your CAGE 8 is drug, your DAST is drug, and your MAST is alcohol for your geriatric population. And again, you can Google any of these. You can go onto the website, and there's a lot of PDF files. There's a lot of research articles out there that kind of, you know, talk about the validity and reliability and all of that pertaining to your tool. For the craft, this is a tool that I use for our adolescents that are 17 or younger. This is the bottom part of that screen. The top part, for some reason I couldn't format it correctly, but the top part asks the questions, do you use alcohol, yes or no, and then it asks drug questions and all that. And then if the patient, the adolescent, says yes, then this is when it drives you to go down below and ask these questions. And then kind of this indicates the scoring. Now what I find is interesting with adolescents, and it never fails, when I ask the A question, do you ever use alcohol and drugs while you're alone? You know, I get the face, the forehead frowns, and they look at me like I have, you know, 6 eyes, and it's kind of like, what are you talking about? I don't drink or use drugs alone. You know, only addicts do that. Only alcoholics do that. And so for a lot of times with adolescents, that is the one question that seems like, you know, kind of like the odd man out. You know, no, I don't do that. And usually I ask, so does that mean if you start using this substance while alone that you might see that there's a concern? And then again, it goes, that's when they say, oh, you're an alcoholic or you're an addict when, you know, when you start doing that. So I always find that very interesting. Now I'm going to give you a vignette of, and that's kind of, I'm going to give you different vignettes with these screening tools. And I have a 17-year-old single white female, a level 2 trauma. Level 2 being that the patient was not intubated at the point of arrival. Motor vehicle rollover crash, broken leg, head trauma. Her blood alcohol level was a 0.57. Obviously, she's underage consumption. Her 18-year-old boyfriend died on the scene. He was the driver. Parent unsure what to do. Dad was kind of like at its wit's end, and patient has a family history of alcohol and drug addiction in the family. Even before going in to see this patient, I already know that this is a patient that is very, very high risk. With this alcohol lab, now we have a boyfriend dying, we have the grief associated with that, we have a family history, and guess what? She has a broken leg, and she's going to be discharged from our facility with legitimate pain medications for that broken leg. So needless to say, before even seeing her, red flags are all over the place. So I do her this craft screening tool. She met 4 out of 5. She drinks on the weekend 6-pack or more, sometimes 2 to 3 shots. Injury was related, family history of addiction, mother in recovery, prior legal charge when she was 16, and that was information given to me by Dad. Patient, you know, just was really struggling with communicating with me because her focus was the death of the boyfriend and his funeral. And then, you know, pretty much I don't have a problem getting me out of here so I can go to my boyfriend's funeral, and that was her focus. Needless to say, I was able to do different interventions with her while in the hospital. That's the benefit of doing screening and brief intervention on a trauma unit, is that some of these patients, because of the nature of their injury, you know, there can be multiple interventions. The result was I validated her desire to attend the funeral. That was clearly understandable. And then I expressed concern of her use in relation to prescription medications needed for her current injury. A lot of my support was supporting her father, who also was in recovery over 10 years. And he was familiar with Al-Anon and actually had attended Al-Anon on different occasions. And then, because she was still under her father's plan, I was able to assist him on how to identify and make the necessary call with his insurance provider. Even if this young lady wanted treatment that given day, there was no treatment center in our area that was going to be able to take her by the mere fact that she has a broken leg on pain medications, and her mobility in a treatment center, residential treatment center, was unlikely. The audit tool, which is what I use for adults, and it's these questions here. It's your 1, 2, and your 3, which is your audit C. And you can actually look up audit C on the internet, and there is a PDF file of the scoring to use. And then again, when you're looking at referral and treatment, obviously you're looking down here at the 20 to 40. But I tell you what, I'm being honest with you, there's sometimes if I have a patient that falls here with their alcohol use, but there's a lot of mental health history and their drinking was more excessive at one point, I don't have a problem referring someone at this level. The other thing to keep in mind, because I do not use the DAST or any kind of drug instrument, because when I do this screening tool and I gather all my information, usually somewhere on the side or the back of this form, I am saying, do you have a history of marijuana, history of cocaine, history of other substances, and I'm kind of recording that as well. So what you'll find in one of my vignettes is I have a patient who falls here as it pertains to her alcohol use and education, but clearly needs residential treatment or could benefit from residential treatment from her drug use. And the reason I say residential treatment because I've been in the field for so long, based on her history, I kind of knew that that would be a great good indicator for her. So here's a gentleman, a 31-year-old single white male, level 2 trauma, ATV, accident, head trauma, multiple facial fracture. Patient appears intoxicated. That was what was in the medical record. I did not have an alcohol lab. So patient appears intoxicated was the reason that I saw the patient. He scored with an audit of 9. He drinks 3 times weekly. He's 8 or more beers on each occasion. Patient acknowledges that his injury is related to his alcohol use. And parents, particularly mother, has voiced great concern of his drinking. And speaking with this patient, again, he was a 19, he wasn't a 20, but in talking to him, you know, he had began to see where his drinking was starting to really escalate in advance and get out of control on some occasions. And in he and I conversating, he said, yes, you know, I'll do a further evaluation. And then patient did have insurance, so I instructed him on how to access his insurance for substance abuse services. My next is my older adult male. When I met with him, his exact words to me, it was my birthday. He was a 70-year-old divorced white male, level 2 trauma, fall, lost balance on sidewalk, head injury, he had a real severe laceration, facial abrasions. Patient reports that he went to the bar to celebrate his 70th birthday, and his BAC was a .27. Adult children very concerned about the incident, and patient resides alone. Upon completing his screening tool, he is an audit 21. He reports that he only drank twice a month. The reason the question mark is there is the daughter kind of raised her eyebrows. The father had given permission for the daughter to be present, and when I always kind of sit so I can see everybody, and the daughter's body language kind of indicated to me that there was more to that picture. Consuming 6 to 8 mixed drinks on each occasion. Now, when we look at the drinking standards for older adults, men from 18 to 65, 2 drinks a day, 7 days a week, 14 drinks in a week. Once men hit that 65 age, their alcohol standard drops to that of an older adult female, 1 drink a day, 7 days a week. So keep that in mind until we get further down here, because he's consuming excessive amounts of alcohol, so he is even overriding the standard. He reports past history of excessive drinking, cut down due to medical problems, past 3 prior OMVIs, and look, we have these medical problems of heart, arthritis, and he's taking medication. So for that alone, if you look on the NIAAA strategies for cutting down, there's a little box on the right-hand side that gives the standards of drinking for for adults and older adults or seniors. But there's a small box, there's a small little asterisk at the very bottom that says, however, pretty much if you have medical problems or medications, it may be recommended that you abstain altogether. And obviously in this case, that would be recommended for this gentleman. I was real concerned about his potential alcohol withdrawal, and the only reason is because of the daughter's raising her eyebrows. Daughter was not willing to disclose a whole lot of information. When I asked if she would like to share anything, she just kind of shook her head no. But I wanted the nurses still to know that, okay, he's only saying 2 times a month. Daughter raised her eyebrows. It might be more. Watch out for potential CERA protocol, and they did. And then he was resistant for further treatment. He just was not hearing that. Some other facility. However, he did have a very strong relationship with his doctor. His doctor expressed concern about his drinking in the past, so he was willing to go and communicate further with his primary care provider as it related to his alcohol use. And again, here's a gentleman that most likely, I don't know his discharge instructions, but chances are he now has been sent home with a legitimate prescription medication for pain due to his injuries, and now, as you can see, he has other medical conditions and medications. This is just a grid of what our audit, when we do our results are. We don't see many adolescents. We might see 1 or 2 a month, if that. Last 2 months we haven't seen any. They primarily go to Children's Hospital. But here is a clear indication when we talk about screening and brief intervention. A lot of people, and even at treatment centers, will say, hey, we have these waiting lists already. You start screening all these people, there's not going to, we're not going to be able to serve them. And I think it's important that we kind of look to see that, when we look at referral to treatment, it's 17%, possibly 4.9%. If we just looked at these, we have our alcohol. And so when we look at binge drinking, there is a great YouTube on the CDC, Center for Disease Control, has on binge drinking. Just do YouTube and click up CDC binge drinking. It's about 4 minutes, but anytime you do a presentation, I think it's important when we're trying to push for screening and brief intervention that we understand that binge drinking falls heavily in this area, where we're trying to prevent and provide intervention to prevent the progression to the zone 3s and the zone 4s. But it's a great tool. And then we have some that says, hey, you know, lady, I don't want to talk about this. You know, it's not an issue, or it is an issue, and I just don't want to talk about it. And, you know, we have to respect patients for that. Now, I'm going to show you a different slide in the down the road here that's going to show there may be some patients that fall in these zone 1s and these zone 2s for alcohol, but they're daily marijuana, daily cocaine, or heroin. That their drug of choice is an illegal substance. They may use alcohol as a way to kind of sedate their high, or they just occasionally use it. So whenever I give my results, I always just say, hey, don't get tricked by this, because some of our illegal substance users are in this this category here. Talking about the illegal substances, you know, we have the marijuana, the painkillers, and, you know, I don't know, you know, according to the roster, you guys are from different states, and, you know, the prescription drug epidemic is nationally and hitting more states than others. In Ohio, it's huge. You know, there's the fear that these pain relievers are going to surpass that of the marijuana. But what I always say is that, you know, alcohol and prescription meds are our 2 legal substances, and, you know, they're right on top. Marijuana in the trauma center, you know, it's, you know, folks think it's candy. It's no big deal. And, you know, I have to respect them for that point of view, but the advantage that I have on the trauma unit to get their ear and their attention is to say, hey, you know, we're going to treat your pain here, and our doctors are going to send you home with some kind of a pain script for your pain, but, you know, they have the right upon follow-up, if you're still using these substances, that they have the right to deny continued prescribing that medication. Because if you look at any pain management material or articles, you know, any illicit drug use is a risk factor for prescribing medications. Now, some doctors outright, I've heard some patients say, won't even see them for pain management. Some doctors will say, okay, however, you're going to have to sign an agreement that while I'm prescribing these pain medications, you will not use. I can test you at any point, and if you continue to use, then if I continue to prescribe these meds, then you're going to have to go to treatment. So that's one of the things with the marijuana, particularly with patients who have these severe injuries, and they're like, well, my marijuana is no problem, my marijuana is no problem, and I say, I hear that. However, as it pertains to this injury and ongoing care and medication, some doctors may refuse to prescribe the medication ongoing, and that seems to get the attention. Now, when we look at the drug use, this is a little, so I do an audit tool on everybody, and then of course I get the drug history, and from that drug history, the counselor and I kind of, on a research data sheet, kind of record what we found. And so 50% of our patients in the January did not use any illicit substances, and then of course we had the one that was 34, about 35%, 9% prescription, and then 6% both. Okay, so, you know, we are capturing, and, you know, so if I have someone who's not drinking on a regular basis or don't like alcohol altogether, I'm still referring this person to further evaluation in a lot of cases. And then, of course, some of the folks scoring here also are using alcohol as well. So when I say both, it's the prescription and it's the illegal. Here's a case. I'm in pain. This was her exact words to me when I went in to see her. She's a 20-year-old, underage, single female, level 2 trauma, MVC passenger, motor vehicle crash. She was a passenger, boyfriend driving under the influence. She has a pelvic fracture. Here's one. Audit C is a 3. So we have an underage consumption. Her alcohol use should be obviously 0 tolerance. In her indication, she rarely drinks. She has a history of abusing prescription medications. Now, this here just, you know, raises the hairs on my neck when I read this, because why? She has a pelvic fracture. She has a history of abusing prescription pain medications, and guess what? We're getting ready to prescribe pain medications for legitimate reasons. And so now it's like, you know, the uh-oh when she goes home. She's completed inpatient treatment program in Florida within the year. She did not complete the aftercare because she moved to Ohio. She has a mental health diagnosis. She has not been on medications for a past month. She had major tension between mother while in the hospital, and a lot of it had to do with the drug use, and mom, you know, just at her wit's end. It was kind of like this incident was enough, and the boyfriend, and it was just very heated interaction. So with her, some of the red flags right off was pain management consult. She was going to be in the hospital for a little bit, and this is where I said that T, screening, brief intervention, referral, and treatment, sometimes that T isn't necessarily waiting to get somebody to a treatment center. It's, you know, she's going to be in this hospital now, and she has a history of abusing these, so her opioid tolerance is already there. And so it's going to be very hard for our nurses to manage her pain. And see, you know, when I see stuff like this, you know, this also is a customer service nightmare, because if the nurse does not see this or know this information, she's going to go in, she's going to medicate this patient, and the patient's going to continue to be a 10-10-10 because we're medicating her based off of a naive pain patient. If I don't tell them that she has a history of abusing these prescription meds, whatever all they, what all she's using, you know, the nurse is going to get frustrated because, 10-10-10, the patient's frustrated because no matter what they give her, it's not going to meet where her tolerance is. And so my thing is pain management stat. And so I usually go straight to the nurse practitioners to say, hey, get pain management involved, because this lady is going to have a very high tolerance. Provided support to patient. I provide support to the patient during the hospital stay. I address history of abusing prescription medications due to current injury and course of treatment. I told her about pain management. I think that's the one thing that pleased her, is that some of her frustration was that she was in pain. Some of her frustration was mom, very angry, frustrated over the circumstances. This was just kind of like the last straw. So, she has, she's emotionally all over the place. This new pain, it was just a lot. And we identified potential treatment providers. Now, I think it's important to see where she had said, I do not need any more treatment, get me out of here. From her standpoint, she did inpatient treatment. Yes, she has relapsed. She had not been using as much as she was using prior to going into the inpatient program. I can't remember her case right off, the details, but I know she was using a couple times a month. Now, as a substance abuse provider, of course, with her history, I want abstinence just because of her history. But you know what? I have to give this young lady credit for the work that she has done, because she's given herself credit. From her point of view, I'm not using what I was using before I went into treatment, so I'm better off. Whereas, some could say, well, you're not abstinent at all, and, you haven't done anything. And I was not, going to open that up. The bottom line was she had done some work. And then, of course, with mom, while, I kind of separated mom and her. I began to have just individual sessions with mom, as she came to the hospital, just to kind of hear her out and, begin to introduce the whole Al-Anon support to her, because she was really unsure of what to do and where to go. Okay, so a lot of information. I will open up for questions, a few questions regarding that particular area.
I have two from the same person. First, are there specific interventions for counselors to use to assist a patient like this? And what he meant was a patient who is there for pain. Did you understand that?
Yeah, I think I did. What are some of the interventions? That's what we're getting ready to go into now, is the brief intervention. Motivational interviewing, I pretty much, I'm not a specialist in it. I'm not a MENT trainer or anything like that, but I usually use motivational interviewing for every single patient, every day, all day, because it's important that you kind of go in with each patient differently. Just your patient in 510 is not going to be the same as your patient in 530. So the whole compassion, the support, the empathy, the kind of understanding of the patient's point of view, but also at the same time from a medical professional providing the feedback needed due to some concerns related to drug use and prescription medications. And we'll go over some of that.
Okay, that was it.
Okay. Brief intervention, a couple resources, that I think that are good out there that has been very beneficial to help train some of my staff is the treatment improvement protocol through SAMHSA. It's a TIP Series 34, and then Hazelden has a lecture format DVD and a book that patients can or staff can view to kind of get some ideas, and then actually get CEUs from it if you complete the test and mail it in. So one of the models, there's a couple models that I know that are out there, and there's probably more, but this one here is the one that I use. It's the FRAMES model, and like I said, if that treatment improvement protocol is a great instrument or a great book to kind of really dive into each of these as far as the feedback, responsibility of the patient, advice to change, menu of strategies. And this is just a framework that I use. So and I can't say, if I had to say what do I do first, pretty much it's the empathetic counseling style, going in and just the respect of patients, regardless of what their alcohol and drug use, whatever their history. If they're a person, I'm acknowledging them as their name. Sometimes, I've noticed in the medical field some of the derogatory remarks that can be made regarding patients, and I don't really have a tolerance for that. When I hear that, the staff kind of knows, Geneva's educated folks, so when we have new people come in and some of that negativity is demonstrated, I professionally just kind of say, hey, let's respect patients and keep their names. If you need to refer to them regarding their substance use, keep it clinical. And I know the buprenorphine website, and I believe it's on the end of this, of my PowerPoint, but I'll give it to you now. It's the NAABT.org. If you go into their publication section, they have a great PDF document that talks about the clinical terminology to use when working with patients. We really have to get rid of the pill heads and the crackhead and stuff that's just so derogatory. And it's just really no place for it. So I would say going in, I'm introducing myself and I'm honoring that patient from the beginning to build that rapport. And even when I go to begin to give the patient the feedback of why I'm here, whether it's the lab, the documentation, EMS reporting alcohol on the scene, the doctor smelling of alcohol, the patient reporting alcohol use. So I'm kind of communicating why I'm there. And then a lot of patients, some, I can't say a lot, but some are offended. It's kind of like, well, why are you even testing me for drugs and alcohol? And so I support all, any of you that are doing this intervention based on your setting, that you kind of have 2 to 3 lines of why you're doing what you're doing. And so, I'm empathetic, I'm going in, and I'm giving a patient their feedback on why I'm there, the labs or my findings, and then boom, the doctor's had done an alcohol and drug test. Because of the nature of your injury, chances are they thought you might have to go to surgery. Anesthesiologist wants to know what's in your system. You're up on the floor, the nurses are medicating you with pain medications. The nurses need to know what's in your system, any fear of drug interactions. And 3, hey, you have legitimate injury here. Chances are you're going to be discharged with a pain medication. And, this positive alcohol lab concerns us because, we need to educate you on, as you're taking these medications, that you don't use on these medications, or if they have a history of prescription drug abuse. And so this is my reasons why I'm there. Responsibility of patient, obviously, is I'm looking for honesty. I'm going to get that sometime, and I'm not going to get that sometime. I'm appreciative, when everything seems to match up, and I'm appreciative when it doesn't. It's not about getting anger or feeling as though a patient lied to me or getting offended. It's just, if anything, it tells me more to what's going on with the patient if they have to be dishonest with me about their substance use. That tells me a lot. The advice to change is now based on my findings, based on the screening tool that I have completed. All that together is now where I'm making my advice to change and my menu of strategies. And this is where that whole issue of referral to treatment comes up, which can be a slippery slope for some patients because their whole thing is address it here, but I'm not doing anything outside of here. That's where that stigma comes in some cases. But I think when we look at the referral to treatment, we start looking at the treatment levels of care, we have to be mindful that when we start saying referral for further evaluation, referral for treatment, patients want to know, well, what does that mean? Most don't know. Usually it's a further evaluation. What I usually say is if someone's going to meet with you, kind of like what I'm doing, and they're going to meet with you a lot longer, maybe anywhere from an hour to 2 hours to gather more information. And from that, you and that clinician will determine, based on the treatment services that are available, where you fit. Now, what I commonly hear, I'm not going to know 30-day treatment. I'm not going to be locked up. No one's going to lock me up. Well, I don't know of a treatment center, I know in Ohio, let me just stick with Ohio, that's going to lock anybody up in a treatment center. A mental health center, yes. Dual diagnosis, yes. Mental health, substance abuse, no. It's usually a voluntary thing. So that kind of dispels that. And the other thing is, I was in the field in the 90s when, and I know in the 80s and 70s, insurance companies were paying those big block 28, 30 days. That's not happening today. Treatment centers are stretching those days out based on every 3 to 4 to 5 day review, no different than a hospital, to justify that continued stay. So I think that's very important that patients' myths of what treatment is, that's where it's going to be real important that you understand what is treatment and what are the options of treatment. If I have someone who's drinking alcohol on a daily basis and they look a good candidate for a formalized treatment program, outpatient, intensive outpatient, ambulatory detox kind of stuff, that is going to look a little bit different for a patient who needs medication-assisted treatment, which is your methadone, your naltrexone, your Antabuse, your Suboxone, for someone who is opioid dependent. So, as you're learning this stuff, it's important that you kind of know the difference between levels of care, which we'll talk about, difference between medications. When it comes to medications, I kind of group the methadone, Suboxone, buprenorphine and all that, no different than we're prescribing medications for the heart disease, we're prescribing medications for diabetes, we're prescribing medication for anxiety, depression. Whenever, you open the medical field up to address something, they're going to start looking for, medications to assist patients, and those are available. Now it's a matter of, does a patient have the insurance and all that? And these are all factors that you have to kind of consider as you're going in. I'm going to go to the next slide because it kind of breaks it down. This is just a kind of like a cheat sheet that I have used. Sometimes they get overwhelmed, like, okay, we got this, they're glad one minute because they have this framework, but they're scared to death because it's like, okay, what do I cover in each one? And this is just kind of a general way to say things that can be covered. Like I said, I usually do the reason for testing, the lab screens, and exploring the patient's response to findings. After all this and you're doing the audit, in my case the audit, I find my result and I'm saying, Mr. Smith, you're falling within a zone 4 of the audit. I need to be mindful to explain what that means, because he doesn't know anything about an audit, nor does he know anything about a zone 4 and a score of 20 to 40. And that's where I'm going to help him understand, one, his drinking, his pattern of drinking that is hazardous or harmful and causing major problems. And then I'm using the screening tool that I use to kind of support the information he's given me. He's experiencing alcohol withdrawal. You're having blackouts. This is your 4th OMVI. All that stuff to support now why I'm making that referral. Patients just aren't taking just any kind of referral. They want to know why. And then, of course, we talked about responsibility of the patient, but also beyond just honesty and just, give, because, if a patient isn't going to tell you the truth, then, your screening tool is kind of, in some ways null and void, but that doesn't mean we don't do it. We go based on what the patient tells us. the follow-up care, the absence of alcohol and drug while taking medications. And the other thing is release of information that, if you have a patient who's saying absolutely, I want to seek that treatment, before you're making a call to anybody, you need to complete that release of information. Advice to change, again, referral for further evaluation. What does that mean? For some people, it is further evaluation. As the vignette I showed you, the 70-year-old gentleman, hey, he had no buy-in to any kind of further evaluation, but he was willing to see his primary care physician. And hopefully in that conversation, if the physician makes a referral, he would be more receptive because he has that trust factor versus me, he just met me. The reason I put therapist because there are some people who are actively in treatment programs or who just recently completed treatment programs who relapsed or lapsed or they're abstinent from alcohol but they're using the marijuana, or they're absent from the marijuana but they're using the alcohol, or they are on a mental health team and they're using substances. Usually I'm asking referral of information, release of information, so I can consult some of these providers to say, hey, one of your patients are here. One, can you come and visit them? And or two, hey, just FYI, they were in a motor vehicle crash and they were using substances, and I see that they're on your team. So those are some other things. Menu of strategies. Again, being mindful what the levels of care are, what medication-assisted treatment, the community resources. Let's look at the legal. I'll cover this also later, but just the other day I had two gentlemen who were, due to the nature of their injury, they're admitted to the hospital, but they're incarcerated in the hospital. They have handcuffs. Police are right there in the room. I usually don't like doing interventions with police officers in the room for obviously a lot of reasons and just the whole confidentiality thing. So I usually ask them to go outside the door so they don't hear our conversation. Most do. If they don't, then I'm usually giving the patient a packet. But here's some, a lot of times, yes, I want treatment, my life's out of control. They're going to jail once they're discharged from the hospital. So, some people will say, well, why are you referring anything to them? They're going to jail. Well, because there's such thing as drug courts. And this person, I look at their demographics to see if they have insurance. Whether they have insurance or not, I'm saying, hey, whoever your legal representative is, if you feel that this is an issue and you want treatment, there are such things as drug courts. I don't know how, based on your charge, what judge you're going to see and how that works. But if this is something you want, you might want to bring that up. And then, of course, I have a document that I have pulled from a SAMHSA publication back in 2008, and I'm more than willing to send it to Kristen, and she can send it to you guys, on drug courts. And it's just a 4-page document. Well, it's a 4-page document, part of a 20-page publication. But what I do is I ask the patient, would you like to know more about drug courts, so that when you go, and if this is something you want to do, you can at least know what you're requesting. And I haven't had one patient, refuse it at this point. The insurance providers, insurance providers pretty much dictate, where patients are going to go. So a lot of times, I, really show them, how to initiate that process. Very few want me to, call the insurance company. It's something that they pretty much want to do on their own. But some of that is because with a trauma injury patient, a lot of times due to their injury, they're unlikely to go into a treatment center right away anyway, because they have to do different surgeries and stuff like that. But in some cases, with some of our patients who have public assistance in this area, Molino or CareSource, they have a great case management system, and I have no problem if the patient's willing to sign that release of information. I can at least contact them. They usually, I think I'm batting 4 out of 5, they usually will speak to the patient while in the hospital, gather all the information they need. The case manager knows that the patient can't get into treatment right now because of medical injuries and or medications, but that they're going to create that relationship so that when the patient is medically able or can, it's there. So I feel good about that. And then, of course, strategies to cut down drinking. There's a great PDF through the National NIAAA website that you can pull that sheet down and really have intervention at bedside. The empathetic counseling, I think the question earlier is, what approach? The brief intervention is one approach. Motivational interviewing is very effective. I don't think I posted this in these slides, but there's a great book. It's called Motivational Interviewing in the Healthcare Setting, Helping Patients Change Behavior, and that's by Rolnick, Miller, and Butler. Motivational Interviewing in the Healthcare Setting, Helping Patients Change Behavior. And it's a book that kind of really makes it specific to the medical field on how to address, how to use this intervention. And then, of course, the last component is the self-efficacy. That non-traditional attempts to address substance use. I'm all for treatment centers. Like I said, I've worked in them for 16 years. They're beneficial. They're needed. We need them. But we've seen that 95% of the people that need treatment don't go to treatment, and we have to look at that. There are some patients that want no part of a treatment center. They're more faith-based. They want to go to church. They want to see their pastor. They want to talk to the deacon. They want to go to the altar. They want to be baptized. If that's the route the patient wants to go, non-traditional attempts, then you know what, I'm having that conversation. Rick Warren out of California started a program through his church called Celebrate Recovery. In the Ohio area, I know particularly in the Columbus area, it's real big, and it's some churches that have actually ministry teams of Celebrate Recovery, and there are some churches that are just really like busting at the seams with support groups. It mimics that of your 12-step recovery program. The difference is AA used the big book. Celebrate Recovery is more Christian-based, biblically based, and they focus more on the Beatitudes. 5A's model, this is one of the models that my friends out of Kettering, their hospital uses. My thing is it's kind of the same. You just, you're asked, it's given advice, you're assessing, that's your screening, you're assisting a patient, and you're arranging. That's where your referral to treatment and treatment kind of falls. But again, you can't do anything with the R and the T if you haven't done the S and the BI. They all go hand in hand. And then here, motivational interviewing, it's very patient-centered. It's helping the patient clarify and resolve ambivalence. If a patient says to me, I drank 2, my alcohol level couldn't be that high. I'm not confronting them on, no, you couldn't have drank 2, you had to have drinking more because. No, I'm saying is help me understand what your 2 was. It's not a fight. I think it's, in some of the literature, it's more of a dance. If a patient, I love this one. Whenever I ask questions, patients will say, I ask, how often do you drink? And they'll say, every blue moon. And, I look at them, and they look at me, and I look at them. I'm like, can you explain to me what every blue moon means? Patient says, well, once in a while. Can you explain to me what that means to you? Every on occasion. I mean, it's just amazing, but what it does is it helps the patient. I try not to be the expert. I want to understand what they're saying to me, because when some patients say, I drink socially, some people socially is every 4 to 5 hours. Everybody's social. Some people socially is with their peers. So I say to them, well, what does socially mean to you? And so that whole, just getting a better understanding of where the patient stands. Stages of change, here, it's just, part of the whole MI, getting a better understanding of where the patient resides as it pertains to their substance use. I don't have a problem. I don't know what you're talking about. You're overreacting. Everybody's overreacting. And again, it's based on their screening results that kind of determine, how you respond to this. Aware of the problem and the desire to behavior change. It's kind of like, yeah. I see that there's a potential problem here, maybe. Preparation, yes, help me. Intends to take action. And this is where here you're not making a referral here. If this conversation is going, I don't have a problem. This is everybody's overreacting. Just let me out of here. Again, I'm going to try and move this patient up these steps. Sometime I'm helpful. I mean, sometimes I can do it. Sometimes it just doesn't work that way. But it's your contemplation, but it's really, your preparation of willing to do it. For the patients who are saying, hey, yeah, I'll talk to the case manager's office while I'm here, they start, going in between these different stages. And you know what? We can't ignore these people, because these are people who have done very well, have been, in recovery. It can be 3 months, 6 months, 9 months, 5 years, 10 years. But you know what? When they experience a major trauma injury and they have to come in and these doctors and nurses start talking about pain medication, these folks are scared to death, because their first thing is that if I take that medication, that means I've relapsed. And, I get to that patient's room no different than if I have a patient who has an alcohol level of a 0.25 or daily cocaine use. Why? Is because, I want this patient to know your recovery is as stable as it is before you came in here. And you know what? We're monitoring this medication for you. You are not abusing it. You have not relapsed. This is for medical reasons, and we're going to support you here for when you leave out of here, and helping them design a plan on how to maintain their recovery despite this injury. The people who have a history of opiate dependence, particularly medications that we might be giving them, mimics that of what they abused. They're really scared to the point that don't give me anything, and based on some of these injuries and surgeries, that's not possible. So that's really tough. Stages of change. This is just kind of an example of of where patients, despite intervention, there are some people that just say, hey, this isn't an issue. And some of it is simply because people feel that if they don't drink on a daily basis, it's not an issue. And I don't, and in meeting with patients, I kind of share, hey, it's not about drinking every day. It's about, when you drink, how much you drink, and what happens when you drink. That's what I want us to focus on, because a lot of patients will say, hey, I'm not drinking daily, so it's not a problem. Once I go from, okay, let's not look at the daily drinking. Let's look at when you are drinking. This is how much you're drinking, your over-recommended guidelines, you're having these injuries, you've had this injury. And I tell you what, there's a lot of people who've died, that I have seen die, and I never get to see them because of their binge drinking. So we cannot underestimate that. So it's real important that we continue to try and push some of these folks to understand the severity of their alcohol use. And it doesn't necessarily mean they have to enter treatment. In some cases, that is the case. In some cases, just basic knowledge so that they can begin to look at their substance use to avoid a future progression into a substance use disorder. And then educational material, this is one. This is where strategies to cut down. It's in that if you don't have this, go on the website. You can actually get these for free. I think you can order 50 at a time. Great resource that we hand out to patients and use as an educational instrument at bedside. All right. I have like 3:14, so I can open up for questions, and then Christine, we can include the rest into part 2 next week, or I can cover some and then we cover the rest next week.
Sure. That's up to you. I don't really have any questions this time. Somebody was asking about the name of a website you just provided, but I know you've done quite a few references, and I think that maybe after this webinar, when you send the PowerPoint between the two of us, we can find a variety of suggested websites for people to go to, and I can list those when I send the PowerPoints around.
Yeah, and even on the PowerPoint at the very end, I have a lot of the different resources on some of that. So yeah, I don't have a problem with that.
Okay, yeah, that's great. Okay, I'm just getting some nice comments now about how much they enjoy the webinar. And also, I'll let you go back and finish up what you want today, and then I expect everybody back next Wednesday at the same time. Okay, go ahead.
All right. Well, what I'll do is I'll cover just a little bit more, and then we can kind of ask questions and go from there. When we look at referral to treatment, I think I've kind of covered the stigma associated treatment, but there's something, a lot of times some of us don't like statistics, but you know what, the statistics kind of tell it. And again, this is the National Survey on Drug Use Health, and it's saying, hey, most people are going to the self-help group. So when we start looking at self-efficacy, we really have to really explore not only or be aware of our options that are available to patients, but what are their internal motivators for themselves. I've had patients say, hey, I don't like that 12-step, that AA, NA stuff, because when I go, you know, sometimes I feel like when I leave out of there, I just want to get high or I just want to drink. It triggers me. Okay, so then what I say to the patient is, tell me what you have tried. But I think it's important that self-help groups is beneficial. It is proven effective. Does everybody bite that interest? Not necessarily. And then, of course, we have the outpatient treatment. Most people do not like the idea of inpatient programs for a lot of reasons. For men, one of the common is I have to work. I can't go into that inpatient program. I have to work. I have to support my family. I'm homeless. I need an apartment. My wife and I, we just can't do that right now. That whole inpatient, so there's that receptibility. Most people are open to an outpatient program. Now, here's my thing. I don't even get frustrated, having been in the field for a long time, I see that there's different failed attempts, whether it's formalized or not. Hey, if a patient says to me, I'm only going to do outpatient only, I'm okay with that, because you know what? When they go to that outpatient program, it's built into the treatment system that if a person is unable to remain abstinent from substances while at that level of care, guess what? They get bumped up, or they're recommended to get bumped up. Now, whether the patient goes or not is totally up to them. There are the inpatient rehab centers at some people, and then there are some people who are like, you know what, there's no way I can get clean on outpatient. I have to go inpatient. And lo and behold, there are some family members that are like, I don't want them outpatient. They need to get inpatient to give me a break. And then we have our outpatient mental health centers. I love the fact of, all of the programs that are occurring now of the whole dual diagnosis, the treatment centers that are now, over the years, addressing mental health in their settings, and then a lot of the mental health centers, like I said, I mentioned earlier, here in the Columbus area, we have these different teams at some of our area mental health centers where they're addressing both mental health and substance abuse. The hospitals, I just think, the whole big hospital initiative, there are some hospital treatment programs that are linked to a hospital system, but most aren't. But like I said earlier, and it just came up on me, when we look at that T, there are a lot of hospital systems that have to address that alcohol and opiate withdrawal, because our patients are in the hospital system, and we need to provide that. Private doctors' offices, the emergency rooms. I don't know about some of you, but in Ohio, with the whole prescription drug epidemic, they developed prescription drug guidelines. And I believe it was Washington State that they mimicked their guidelines from, and out of that there was one element that was to provide some form of intervention for patients in the emergency room. Now, when you look at screening and brief intervention, one thing that's not going to change is components of screening and brief intervention. But I can't stress to all of you enough that depending on your setting really determines the tool you're going to use, the timing, the staff that you're going to use. Because I tell you, when I go down to an emergency room and meet with a patient, it's a lot more hostile and challenging with staff and patients in the emergency room, because there's so many competing challenges, the waiting list, waiting for the results, the doctor hasn't come in to see me, the nurse doesn't, there's a lot more contending with my addressing alcohol and drug use that sometimes it becomes a small focus, although it was a primary reason for the admission. And then, of course, with some prison, there are a lot of programs within the prison system. So with that, I believe we're like at 3:20. What I'll close with, and we'll dive into this next week, is I can't say enough, based on your setting, is that you really have to get the champions who are really on board to do this. I know in some medical settings, folks are just running with it. I know when we did some training up in the Youngstown area, there's a fairly funded healthcare center that, you know, once they received a brief training, they were like, absolutely, and I mean, they're off and running. And then, you know, in different other states of Ohio, you know, they're a little bit more guarded. Some hospital systems are a little bit more guarded. I was talking to one of my friends in Kettering, Chris Heron, and we were talking, and we find it in a hospital system because it's so large, a lot of times you have to kind of navigate all those systems there. So when you look at referral in a hospital, I'm part of a trauma team, but you know what? I have to refer to nurse practitioners and case management, behavioral med, to get involved in the case regarding their alcohol use. But then I also have to go out into the community to the Mary Havens, the Parksides, the OSU Talbot Hall to make a contact. So if I have a patient who wants those services, that I now can go to that phone and I'm talking to that person. I'm not talking to a voicemail. I'm not caught up in the system. I'm trying to make this as seamless as possible in order to help patients get the care they need. So with that, I'll take any questions that are available, and then I'll see you guys next week. Or I'll talk to you guys next week.
Yes, I just have one question. Why don't you use the DAST-1 or the DAST as a screening tool for drugs?
Well, for me, it's timing. Like I said, I'm seeing a lot of people, and so for me to have an audit and a DAST and a CRAF for adolescents. But the other reason is my experience in the field. I did alcohol and drug assessments for years. I actually ran a admission department. So, you know, I don't really need the DAST to ask the questions that I need to ask pertaining to their drug use. Like I said, with my audit, I'll do the audit and I'll flip it over, and, you know, I'll ask the other drug questions. And when I ask the other drug questions, what, you know, are you using this? If so, how much, how often? It kind of, you know, gives me the information that I need. So some of it is I just didn't want to have to deal with another tool. Two, myself and clinicians are experienced enough to gather the information that I need that the DAST could give us.
Okay, well, thank you. And thank you, everybody who attended today and who submitted questions and comments. Thanks for participating. I will be sending you the PowerPoints within the next day, hopefully. And you can use the same login information for next week's webinar session as you used for this week. So at this time, I'm going to close this for everyone. And thank you again for joining.
Thank you.